Hello, class. Welcome to chapter 3. Today, we're going to be talking about the art of clinical exercise programming. So, this will be a little different from the last two chapters that we looked at. So, those two were giving some general guidelines about what are the ACSM guidelines? How is this book different? CDD4. Well, today we're going to be talking about what is the art of clinical exercise programming. So, as we know and we've talked about, many patients with chronic conditions don't fall within a well-developed evidence base. And I mean, the textbook's a little snarky. They say if most of them did, then this textbook wouldn't exist at all, right? All of this could just be a position statement. It could be an article, and that would be that. But as we know, many of them don't fall within this evidence base. And so it's also very common for these um, populations to become medically unstable. So it can range from something really minor, like they're not feeling great on a particular day, which honestly we experience too in the activities that we do. They might experience an acute exacerbation of their condition, but it just stops. So maybe it's, 1 or 2 weeks and then they're feeling fine again. Could be an acute illness, or in the worst case, they could develop a new condition and it could either be life-threatening or it can't be. So basically, there's a lot of different things that can happen that is going to make us shift away from guidelines and have to be really creative. So the point of this chapter is to address that. And all of the following may cause a patient to overall feel some fatigue, weakness, depression, pain, shortness of breath, and other discomforts. So, therefore, you, as the exercise specialist, have to be ready to improvise and be flexible to meet the specific needs of each individual client. And as mentioned, little, if any, evidence base exists to guide the art of exercise management. So a lot of it is being flexible. And I guess pulling back from the previous couple of lectures, use your judgment. When evidence doesn't really exist out there in the form of peer-reviewed studies or randomized group settings that are trying out new programs to see how it works for people, gotta use your own judgment. So why don't we delve into it? This is structured into 8 different steps that the book identifies as essential steps for exercise programming. So why don't we start with step one? Step one of assessing anything for whoever you may be working with is to understand their current health status. So the history of the disease, their current symptoms, side effects of their condition and treatment, and physical and cardiovascular restrictions and treatments. So what we're talking about right now is pre-exercise programming. So they have not started working with you yet. They are in that pre-exercise portion where you're reviewing all of their background, essentially, getting to talk to them, understand where they're coming from. So start by determining how this condition has affected participation in regular exercise, leisure time physical activity, ADLs, and IADLs, which we'll talk about a little bit later, those last two. Now, this part may seem a little intuitive, like, yeah, of course you're going to talk to them and understand what their background is, but actually there's a lot of different nuances in this specific step. So people have a very different understanding of different terms, and one of them may be just their physical ability and what they define as exercise. So their perception of their own physical ability may differ from each other. So, this may be determined by limitations that they've personally experienced or by messages they've received from others about what they're able to do. So, this is up to you to figure that out. Are they saying they can't do something because they've tried and they can't do it? Or did their doctor tell them they can't do this? Or did their family tell them they can't do this? Um, so also something else that can affect it is experiences of others with the same condition and different things that the patient may have read. So clearly you can see where this is coming from. There could be a multitude of people with the same condition, but their perception of what they're able to do may be vastly different. And sometimes it's legitimate. They've tried it and they know they can't do it or they can't sustain it, or they've just read about it. Like if you have XYZ disease, then you cannot do XYZ activity. So that's up to you to dispel. And then here's some more, I guess, objective things to identify, things that they will tell you based on what they believe personally. So, any absolute or relative contraindications to exercise due to the condition, any clinical or patient concerns related to the safety of participating in given activities, what clinical aspects of the condition might be improved with physical activity, and then what motivates and sparks the patient's interest in starting and sustaining participation. So point number one and point number three here, we actually will cover together in the following lectures. So our chapters will include if there are certain types of exercises that should not be done, um, for any given condition. Um, and then, of course, we will also talk about what aspects of their condition can be improved with exercise. But again, it's not like everyone with a certain condition should not do this exercise or they should do this exercise. It's very person dependent. So that's where the where the relative contraindication part comes in. Also, assess their current level of physical activity. So the recommendation here is to start simple. So ask them very open-ended questions like how much do you walk each day? How often do you climb stairs? What do you do for exercise? And this is in contrast to those exercise vital sign questions that we talked about. Remember, one of them that we talked about is multiplying two numbers, how many times they exercise during a week and how often they exercise during those times. You multiply those numbers. If it's below 150 minutes per week, then they're not meeting some basic guidelines for physical activity. But this right here is more open-ended and broad. Because again, we're still in the pre-participation phase. Um, so asking it this way helps you figure out, what exactly do their lives look like every given week, right? And on that note, a really helpful insight for you to determine before working with someone is how does the patient define exercise? So here's three different examples that the textbook gives us. I like to run and do about 3 marathons a year, but I'm worried if I can do that now with the new condition. I like to ride my Harley motorcycle in the summer and snowmobile in the winter. And I like to play horseshoes and I go to tournaments on most weekends. So yeah, very different levels of activity, right? Um, they are still activities. However, they're not equal to each other. So you should really understand what people mean when they say I exercise, because it differs widely given who they are. Um, a good way to do this is to have patients describe their activities throughout the course of a week. So, this is, leaning into that open-ended question format. So, just ask them to describe what Monday to Sunday looks like on any given week. And as they're speaking, keep in mind any indications of strength, aerobic ability, and endurance. So, things that perhaps they're doing really well already. But also pay close attention to things that are not great if there's any evidence of problems with balance, coordination, and flexibility. So this is for you to glean as they're speaking to you. Also, probe further based on these responses to understand the patient's limitations. So usually you can get a better idea of what people are experiencing as a limitation if it's tied to the activities that they've described to you. So an example for that horseshoe person is, do you get tired enough during your horseshoe rounds that it affects your play? Um, so this is really honing into what they like to do and perhaps also getting at their motivation to start this program. Like for this person, it could be, yeah, it would be great to develop better endurance and strength that it doesn't affect my horseshoe tournament performance, right? So think of these as a couple of different strategies to assess where the patient is at before you even start working with them. Also, that was step two. I don't think I said that. But anyway, we're in step three now. So, step three is identify exertional symptoms that limit physical activity. So, there are three things to look for here: objective value, qualitative descriptions, and recovery time. So, what we mean by objective value and qualitative description is as you're speaking to your patient, Try to find an objective value that limits their physical activity as well as a qualitative one. So, an example is I can walk for 10 minutes before I have to stop because my legs cramp up. So, 10 minutes, that's an objective value. Okay, 10 minutes. That's a really good starting point if you're making an exercise plan for someone. And then qualitative description can be, yeah, before my legs cramp up. Or another example can be I can do laundry for 5 minutes and then my shoulders start to feel really sore. That's that's another example of objective. We have 5 minutes and then qualitative shoulders start to hurt. And then recovery time, this is actually an extremely important thing that you have to note before you start working with them. How long do their limiting symptoms last? So the programming for people is going to be different depending on how long it takes for them to recover from their symptom. So let's say for that person's example, I can walk for 10 minutes before I have to stop. If it only takes a 2-minute break for them to feel fine again and then they can keep walking another 10 minutes after, that is going to be a very different program compared to someone who needs to sit and rest for 10 minutes following their leg cramping up. So this is going to be a it's going to be a really good indication for where you should start these people off in their programming. And often for those patients that do require a lot more time, they'll likely require alternative modes and types of exercise, at least at the start of the program. So ideally, you can help them really increase that threshold, but at the start, it's going to be different. Also, an interesting note here that we will talk about in following chapters, given the specific condition, but depending on the situation, you may want to actually cause symptoms, or you may want to completely avoid them. So it kind of depends on what the condition is. So, um, for example, for myopathy, the activity that's causing symptoms for myopathy should be avoided. You should not be causing that to flare up, right? But there are other conditions, such as intermittent claudication, that actually, the whole point is to induce mild symptoms, but you have to stop just shy of cramps. So not pushing them to the extreme, but getting them to the level where they do have to experience mild symptoms in order to see some improvements. However, just a note on that, we don't want to just go around causing symptoms in exercise, right? One of the main reasons for this is a patient will likely not continue an exercise plan if they experience discomfort with physical activity. And that makes sense. I mean, again, maybe people in this classroom are in a different boat. Maybe we do things that, push us to discomfort, right? Maybe we go on really hilly runs or we ski really scary downhill runs. I don't know. Maybe you do things that do cause you discomfort, but they're for a different reason, right? For these patients, they've probably experienced a lot of I guess forms of trauma because of their condition, and so if they keep experiencing that, they're probably not going to adhere to an exercise program. And adherence is one of the most important things that we want to get to. Um, Also, if symptoms do keep arising, like you're trying to avoid them, but they keep arising, it's up to you to determine if it's a feature of the chronic condition or if it's related to the treatment. So, an example of this is anemia resulting from chemotherapy. Um, if the cause is unclear for any reason, then the patient should be referred for evaluation. All right, step 4, evaluate physical function and performance. So now we're past the pre-participation phase and now we're getting into it. So the book recommends that you evaluate patients based on this basic scale of 4 levels. So we have mildly impaired to normal, moderately impaired, low functioning, severely impaired, very low functioning, and needs aid debilitated. So if a vast majority of people with chronic conditions fall into that first category, where it's just either no impairment or mildly impaired. The book recommends to just stick to ACSM guidelines, the ninth edition that we talked about last time, for these people. However, anyone who is at that moderate level or worse, then refer the patient for physical functioning evaluation. This can be done in a variety of different places. Sometimes it can be with the physician if they have the training for it. Otherwise, it's just different groups depending on what the condition is and how bad it is. But specifically, they should look for um, assessments that include reaching with arms, tremors, coordination, an inability for the patient to bend and swoop, estimating gait, which is common in Parkinson's, and other various neurological impairments. So this is the table that the book gives for these four levels. So it's giving you just a very general look into what types of people may fall into each category. So again, vast majority fall into that mild or mild to none category, so they can walk, jog, or better. Moderate, they can still walk briskly, but at a high RPE and not for long. And so on and so forth. So you can use this scale if you'd like, to have a reference on how to assign people to different levels. Some special considerations in this step is two things. So, individuals with type 1 and type 2 diabetes, be alert for any signs of neurological impairment. These may be really small and easy to miss, but they can be indicative of diabetic neuropathy. And it's best if you catch this early for that patient. And then for individuals with fall risk, perform the appropriate evaluation of their balance level to start with. There's like a million different ways to do this as the book notes. So the book doesn't get into exactly what you should do here, but um, if there is any risk that you think they don't have good balance, that this could be a problem for exercise, then refer them to a therapist trained specifically in balance problems. Um, yeah, we don't want to cause any more problems for these individuals. Okay, step 5. So select recommended physical performance assessments. So these can be like survey style. So for the ADLs, we have the CATS assessment. So these include things like, bathing, dressing, grooming, eating, toileting, and transferring. Basically seeing what level they're at for these general activities of daily living. And then for the instrumental ones, you have the Lawton assessment as an example. And this is more complex things, so things like preparing meals, shopping, handling money and bills, and housework. Also, the book gets into a lot of, I guess, the minutia of commonly used tests for physical functioning. Now, there's a lot of it, and I elected to not go through each one individually just because you've probably seen these and maybe you've even done them as a part of a course. But the good thing about all of these tests is they're low cost, they're easy to do, and there are well-established norms available for assessment, so you can really see how your patient is doing compared to everybody else. The CDD4 recommendations from all of these examples that the book gives is to do a 4-meter gait speed test, a 30-second sit to stand, a 30-second step test, and 30-second arm curls performed while holding 2 kilograms of mass. And they've noted specifically that the 30-second sit to stand is a really good option because if a patient can only do 8 reps or less, then that's associated with poor outcomes overall. So these are their recommendations, but honestly, it will be dependent on who you're working with. All right, step 6, considerations for formal exercise tolerance testing. So we talked a little bit about testing last time, right? I forget if it was chapter 1 or 2. But we talked about times where it's a good idea to do an exercise test and times that it is not. So keeping all of that in mind, it is not recommended to have patients with chronic conditions do a full-on Bruce protocol or even a modified protocol. So the book recommends something like a Balcor modified Naughton protocol or just some low-level constant increment protocols, continuous low-level ramping protocols, or branching low-level protocols. So again, it kind of depends on who it is and what their level is to start with. But the book recommends increase the speed according to the patient's definition of a brisk walking speed, and then just keep that pace the whole time and increase the grade 1 to 2% every 1 to 2 minutes. So the idea with this about, not doing a very difficult type of exercise test is, for one, as we talked about last time, often the results will not be conclusive because it's simply too difficult for them, or they have issues that are going to cause them to stop before they reach that 85% of max predicted heart rate. Also, there are certain populations that you don't want to basically delay the start of an exercise program just because they have to go and get this exercise test. So an example is for people who've suffered a stroke. So if they have to wait several weeks to schedule an exercise tolerance test before they can begin their own program, then that is basically weeks where um, the brain is at the best level to um, what's it called? For neuroplasticity. So delaying that is losing on a couple of weeks that could be really, really important for them getting back to normal life, normal physical functioning. Um, so yeah, guidelines are changing, I believe every year for cases like that, but essentially just monitor this and assess whether it's even prudent to do this, and if so, then to do something like this recommendation where you can actually do it without, going to an actual place. As long as they're supervised, then they can do it with you. Okay, step 7. So here are some considerations for program referral. So here are the 4 things that should be considered in general when you're referring patients to certain types of programs. So the specific limitations in their physical functioning, clinical condition and safety of exercise, patient preference, and a location that encourages adherence. So yeah, again, a lot of different things go into this decision. Um, One of the things to note is sometimes there are clinics that would work and maybe they're convenient for the patient given the proximity, and I guess the hours of operation. But if the focus of that clinic is not to the level that the patient needs, then that is not a good idea. So if they're like a high performance sports setting clinic, then that's not going to work well for a patient who maybe doesn't, can't even run, right? So, PT and OT clinics are a really good option. So physical therapy more so if it's um, just for general conditioning and exercise, and then occupational therapy is better if it's specifically activities of daily living that they need help with. And the good thing about these is that, at least in this country, insurance coverage can continue as long as there is a demonstration of progress toward predetermined goals of treatment. But of course, the caveat to this is if the patient just, doesn't really have any specific um, debilitations or issues and they just need a general conditioning program, then typically insurance doesn't cover that because it's not exactly like a specific problem that's being addressed. And there hasn't been the specific goal placed. So the patient may need to pay out of pocket to cover that. So that's another thing you may have to consider when recommending things for patients. But of course, the main goal of this is that the program should avoid creating a dependence on clinical supervision of exercise. So we want the patient to be able to incorporate this into their lifestyle. And if that requires clinical supervision at all times, then that it's difficult, right? It could be financially really difficult for them, and just on an independence level, if they are not able to do things independently, then their autonomy will decrease, their quality of life will increase, so on and so forth. So the goal is actually to create self-sustaining patients. If they can understand their own responses to exercise, manage and monitor their symptoms, and progress and sustain their program independently in whatever setting that facilitates their ongoing participation, then you are doing your job, and it's going really well. Um, we don't want people to be dependent on others to tell them how they're feeling, how hard they're going. You want them to eventually come to the point where they understand this for their own. Okay, step 8. Develop a strategy for monitoring progress. So, um, this is where, the participant has been with you for perhaps several weeks and so on, and now you have to find a way to monitor their participation. So, monitor their clinical responses and their fitness. And then if there were any functional limitations that were identified early on, then it's a good idea to readdress these regularly, see how the patient's improving, or, I mean, unfortunately, maybe not improving. Now, this is, I believe, the last thing I have for us, but it's maybe the most important one. So, a part of assessing how they're doing is teaching them to monitor any abnormal responses to exercise. So, patients should be well aware that if they experience any of the following things on this list, then they should either go for further evaluation or let you know as the exercise specialist or find another way to manage it. So, excessive shortness of breath, excessive heart rate response, muscle and joint pain that prevents a continuation of exercise even when they decrease the intensity, or if they completely stop exercising and that pain still persists, nausea, headache, and dizziness, lightheartedness, and then I'll fix that. That says chest pain at the bottom. Um, so if the participant is experiencing any of this, then it's very prudent that they either reach out to you about it or go and have an evaluation. Now, oftentimes, and this is best case scenario, they experience this because they're ramping up the intensity a little bit more than what's recommended for them. And so that's why they're experiencing some of these higher values for heart rate, for example, or if they're feeling more out of breath than usual. However, some of these can also point to the development of other types of conditions. So perhaps if they're experiencing chest pain or excessive shortness of breath, it could mean that there's something wrong with the heart. Maybe there's, maybe atherosclerosis or one of their conditions is actually trending negatively, right? You never know. So that's why it's very important that your participants know when or what to do when all of this happens. Okay, that was chapter 3. Um, Chapter 4 will be relatively similar, but it'll go off a different path. Again, sticking with this thing of, how do you kind of set up an exercise program for someone. But um, but yeah, so I'll see you guys in the chapter 4 video.